GP and a GP in sunny Bracknell, although it doesn't feel very sunny at the moment. What we're going to do today is talk about the primary care contracts and optimizing quality and incentivization therein. We're going to talk a little bit about, after my presentation, about a new pancreatic study called the EUROPAC trial, which we're going to have representations from. And it's a very interesting one, so we'll go on to that after my presentation. And happy to take questions during the presentations if you want, and certainly at the end as well if we have time. We will, of course, send out these slides to you so that you have these for reference. And there are some links and resources within that that might be of some use to you. If there are any questions that the Alliance can answer for you, please let us know as well in the chat box or by emailing us. We can happily try and support you with that. Okay, so I'm going to make a quick start on the primary care GMS contract in relation to cancer. And we've titled this Optimizing Quality, really. And really, we want to really understand the cancer element of the GP contract. Next slide, please. We know that cancer cases are rising, and it's estimated that there are 375,000 cancer diagnoses each year. We know that our populations are aging more and living longer, and the number of cancer cases are expected to rise by 2% increase in the incidence rate between now and 2035. So that's a big increase, really, in numbers. So in 2035, over 500,000, 500,000 cases of cancer will be diagnosed every year, it's predicted. Currently, there are roughly 55 cancer diagnoses per GP surgery, which means it's about 10 cancer diagnoses per whole-time equivalent GP. And the main cancers are bowel, pancreatic, and myeloma. So cancer is a big, big diagnosis that needs addressing in some sense. Next slide, please. We want to avoid cancer, and I think COVID has sort of reduce the focus on prevention, and we do really want to focus on prevention, which is a really, really crucial thing. Would you mind muting yourselves, please, because I can hear some background noise. We want to focus on prevention, and particular things like smoke-free, healthy weight, safe in the sun, etc. And Cancer Research UK have a very good sort of professionals page on some of this. So please have a look. I'll give you a lot more information about prevention. Next slide, please. Henry, thank you. So where does the quality income come from in primary care? Well, it comes from the GP contract and the PCN-DES. And the points for cancer are about £220 per point. There are 24 points of potential income that can be achieved. The PCN-DES is roughly £2 per registered patient, which means actually that we're practice for about 10,000 patients. The income, and assuming all targets are met, could be anything between 20 to 30,000 annually for hitting these cancer-related targets. So this is quite a big source of income for providing what is very good quality of care for patients. Next slide, please. So we look at the GMS QOF here. We have the registration bit of each cancer, gives you 5 points. We have cancer care reviews within 12 months of the diagnosis, 6 points. Cancer care review within 3 months, which is the opportunity to discuss and inform the patient of support available from primary care, is 2 points. So these are where the points in terms of the cancer care reviews and the cancer register are. Next slide, please. When we talk about cancer care reviews, the patient experience is really, really important. And the survey last year showed that we were quite low in many aspects from support from a GP. So cancer care review is a conversation between a patient and a health or social care professional about their experiences with cancer. And it's very personalized and helps patients to talk about the cancer experience and concerns. You know, diagnosis of cancer really does change a person's perspective on life. So this talking about it is very important, and understanding what support is available to them is very important as well, and receiving the information. that they need to be supported with in terms of themselves and self-management, definitely. And an effective cancer care review conversation really aims to discuss the patient's diagnosis, their understanding, the cancer treatment and its possible consequences, any entitlements like prescriptions and finances, information needs for the patient and their carers, any rehabilitation or physical activity advice, and signposting to local support services, because we know that rehabilitation and optimum lifestyles do actually help recovery from treatments and, in fact, possibly even mortality. There are some fantastic support resources available from Macmillan in how to complete a cancer care review. So please have a look at that. And when you get the slides, you can click on the links, which will give you that. Next slide, please. We also have various IT tools, and certainly on EMIS, we have the Ardens Cancer Care Review template, which should cover most of what I've said and a lot more. So please use the Ardens template, which is very comprehensive indeed. Next slide, please. Another area that we get some quality issues and income issues and incentives is from cancer screening programs. And certainly these are really important from the early diagnosis point of view. So we know the 3 programs, which are breast, cervical, and bowel. And the new one being carried out at the moment is targeted lung health checks. But we know that earlier diagnosis saves lives. We know that more than 9 in 10 people with bowel cancer survive at least 1 year. Whereas only 4 in 10 survive 1 year only at stage 4. So early diagnosis is really important, and screening programs in particular are a way into that. Next slide, please. So in terms of cervical screening, it is the cervical cancer is the 14th most common cancer, with 63% of women survive for 10 years or more. And virtually all cases are caused by the HPV virus. And now we know about the vaccination, which is available to 12 and 13-year-olds and young adults too now, including boys. The screening really is about the women between ages of 25 to 49 and gives you 7 points. It's every 3 years. And those over 50 and 64 every 5 years and gives you 4 points. So it is really quite important to try and get this screening carried out and the numbers uptake increased, enhanced for your practice. Next slide, please. The other stream of income that we have and quality activities that need to be carried out include the PCN Early Cancer Diagnosis DES, which for this year has been published earlier on this year. It states that PCN should support early diagnosis by reviewing cancer referral practice in collaboration with various teams and make efforts to improve support of earlier diagnosis. It also talks about improving screening uptake in the 3 programs. These links will tell you, give you some guidance on all of these things, which I won't talk through now. And there are some superb resources from Cancer Research UK and Macmillan on delivering some of these things, making your lives easier, actually. Next slide, please. A bit more detail. One of the comments it makes is that a PCN should work with cancer alliances to increase early diagnosis rates and improve referral practice, and alliances have allocated funding to support this work. Well, funding already exists through IIF and GMS contract. For much of this, only transformational new funding is available by application to the alliance. So if you have any great ideas, new ideas, which are not in any of these other streams, please let us know. And although the NHS is short of money at the moment, as you all know, we'll try and find some money if it's a really good project that you might be asking money for. They're also saying that all referrals should be looked at. So please use suspected cancer forms and the guidance. And I would suggest to you that remember to send patients the text or the message about leaflets about patient information for urgent suspected cancer referrals, because we want these patients to not default an appointment. They need to attend and understand the reason for the referral. They also want to focus on the colorectal pathways, and what we would suggest to you is to follow the urgent suspected bowel cancer pathway that the Alliance has written, use FIT in all lower GI assessments and include in referrals, aside from those that don't need to have it, and also follow the FIT less than 10 pathway, which I'll discuss in a second. Critically, patient education about why these tests are being done and safety netting is absolutely key here, because we don't want patients to be delayed in making the diagnosis. Next slide, please. So this is the Lower GI Thames Valley Cancer Alliance urgent suspected pathway. It's been supported by NICE and BSG, so it's a pretty robust pathway. Basically, when a patient presents with bowel symptoms, unless they have an abdominal lump or rectal lump or ulceration, GPs and primary care are asked to carry out baseline tests, which includes a FIT test. The FIT test should then be reviewed, and if it's greater or equal to 10, then the patient should be referred in under the 2-week wait rules and pathways. If the FIT is less than 10, certainly if there are alarm symptoms or there's clinical concerns, they could still be referred into the 2-week wait pathway. But if it's less than 10, it's very likely that a cancer has been excluded. And therefore, review, safety netting, and refer to alternative pathways may be an option. Next slide, please. So when a FIT is less than 10, i.e. a negative FIT, this is what the Alliance is suggesting we all do, which is review the patient roughly 4 to 6 weeks, consider other investigations such as imaging, ultrasound, or CA125. The NHS guidance also said that you may want to consider doing a second FIT test, maybe a few weeks later, but only if ongoing clinical concerns remain. 2 negative FIT tests in a recent study have shown that colorectal risk is less than 0.04, and more studies are being planned. So consider reviewing and consider other tests, and maybe, only maybe, offer a second FIT test. Safety netting is absolutely critical with these symptoms and presentations. So please explain and ensure the patient understands what you're trying to do and what the next step should be. Obviously, if the FIT is negative, then you can refer into the non-symptom specific pathways. You can ask for advice and guidance, or you can have alternative pathways in your locality for rectal bleeding, iron deficiency anemia. You may want to refer for advice and guidance into gynae, urology, either as urgent or routine. So, these patients should not be missed in any way. There must be an explanation for the symptoms. So it may be worth referring the patient on, as I've explained just now. Next slide, please. One really important thing to mention is that there have been some rejections of FIT samples, and FIT samples will not be processed if they're received without a name, surname, NHS number, and date of birth on the tube, if they're received in the wrong tube or container, and certainly in my area, the blue top picture here is the one which is for the normal stool specimens and not the FIT test, and sometimes people do send those out instead of the FIT test. So really quite important to use the right kit for them. Samples that have occasionally been received without a request form, and occasionally they've not been labeled correctly. And my top tip to you is just get a label and put it on the tube which has all the right information. Very rarely, but it does happen, the container is overfilled. But these are really important to actually carry out. We don't want FIT rejections. Next slide, please. So the other aspect of improved referral practice, apart from colorectal, is lung cancer. And it's obvious here, really, isn't it? Try and get it early imaging as much as early as possible. The new targeted lung health check screening has commenced now in most areas, or will be commencing next year in some areas. But certainly by 2028 or 30, it'll become a national program. So encourage attendance, and you will be hearing about this more and more. But also, please note that 23% of lung cancers have a normal chest X-ray. So if they have persistent symptoms, then please ask for advice or refer into the 2 great pathways. One of the things that the DES says is that one other cancer type determined locally should be reviewed as well, based on burden of late-stage diagnosis and opportunities for timely and effective referral to support earlier diagnosis. And the Alliance is working with Clinical Advisory Group. And one of the areas that we're focusing on at the moment is the gynecological cancers. With the advent of more and more HRT prescribing going on currently, We're hoping to redesign pathways on unexpected vaginal bleeding on HRT, postmenopausal bleeding, and CA1 to 5. So this is to try and help bring clarity into who to refer in unexpected bleeding. Next slide, please. Also, it says the guidance in the DES says that the PCN should work with alliances and its GP practices to review the recommendations of guidance, audit referrals of those people who received a diagnosis of cancer, and really the templates of the National Cancer Diagnosis Audit is really useful. Use fingertips for data sort of analysis and try and work out areas that you need to focus on. And also assess through audit, probably, different stages in the pathway for improvement. For example, interval between first presentation and when the urgent suspected referral was made, who the patient actually saw, different clinicians, etc. So a chance for audit here. Next slide, please. Also, this is about supporting streamlining diagnosis and referral. Use direct access tests where available, so urgent investigations are carried out as per NG12 guidance if they don't fulfill the pathways. Also, talking about FIT again, it's very important to focus on health inequalities because we know that people living in more deprived areas are more likely to be diagnosed with bowel cancer at a later stage and less likely to complete a FIT test. So you may need to think about how to actually ensure the patient completes this. Try and also address variation in completion of FIT tests in symptomatic patients and deprivation, and patient education and safety netting processes to follow up those who have not returned their FIT tests. So these are all really quite useful things to reflect on and think about how you can, at your PCN or practice, make some changes. Next slide. Another area that the DES mentions is teledermatology, which most of you are probably aware of. This is to support faster skin cancer referrals, and most areas now actually suggest the use of a dermatoscope or photography of skin lesions, refer with pictures, and therefore get an assessment in a very efficient way. Some trusts I know have developed teledermatology pathways in the community as well. So just try and adhere with that. If you have any ideas, please let us know how we can help. The Alliance did actually gift out some dermatoscopes last year and the year before, and we did have some training sessions, but we'll see if we can do some of this in the future sometime if funding is available. Next slide, please. So I thought the next few slides will be about practical tips to enhance the quality, income, and performance in cancer care. Next slide, please. And these are just very practical tips, really. I mean, the basic practical tips are get to know who can help, actually. There are people, clinical leads in your alliances, in your ICBs, in your locality, and they will be able to point you in the right direction or support you in every way we can. Don't start from scratch. Use existing resources, and the CRUK and Macmillan are really good resources to actually turn to. Use data from fingertips to see where variations are and what your gaps are that need maybe sort of addressing. Audit is a fantastic learning tool. Keep it simple, keep it focused, and share any learning. So new cancer diagnosis, as I mentioned earlier on, is a good audit to carry out. Routes to referral is another really good one. And make sure you know what's happening in the area and avoid duplication, because we just don't have enough energy to do all this or time to do this. Others have done it, use it. Link in with secondary care colleagues. Actually, they might actually help you to actually progress efficiently, and work with the patient participation group to see how their experience has been. Be creative with additional roles. So social prescribers and care coordinators, they can all help with screening as well as sort of cancer care reviews, and specifically for harder to reach patients. Next slide, please. Cancer care reviews, one important thing is, are we coding the patients correctly that have been diagnosed? Ensure that the COF cancer codes are used, and the Cancer Ardens template is very useful for that. You know, I think malignant lung cancer rather than lung cancer is the preferred code, for example. So make sure you use the right codes when coding. Who's going to invite these patients? And again, Macmillan have a very good sample letter or use AccuRx SMS Cancer Care Review Florey questionnaire to invite these patients. And as I said earlier on, use care coordinators, social prescribers, others to actually carry out the initial first part of the review, at least actually. It makes it very much more efficient and appropriate. Macmillan has a very good cancer care reviews in primary care on their website, so please refer to that. There'll be a lot more tips for you. Next slide, please. In terms of screening, it's quite important to improve awareness. So talk to people about tests, show them the animations from Cancer Research UK on some of the screening programs, display promotional materials, send positive messaging around screening, send the appropriate links on text messages when inviting patients. Remove barriers, try and have access a bit better now. So have a wide availability of appointments, offer pre-appointments for those people who have specific concerns, use health promotion materials, and letters and text to non-responders and pop-up boxes. All really important to try and encourage the uptake of screening. And also, I think it's good practice in a way and efficient that if you have a nominated lead at the practice of PCN on cancer screening, that makes life a bit more progressive and efficient. Next slide, please. Another thing is use the data, as we mentioned, to look at the variance, look at identify low uptake groups, and audit non-responders and exceptional reporting reasons. And consider the barriers, as I mentioned earlier on. Extended access is a really good facility, evenings and Saturdays, for example, for these healthy, normally working people to attend. Sending videos or text messages in the appropriate format will actually help in appropriate languages as well. Next slide, please. Every contact counts approach is a really good one, that when they attend for whatever they come into, it probably pops up in EMIS in a pink box on the right-hand side. Just remind them that actually they need to have a smear done or whatever. And not just clinicians, but receptionists should be encouraged to do that as well. And use the resources that are available. As I said, Cancer Research UK, Macmillan, etc. These are all available and you can use these resources. Next slide, please. There have been recent sort of problems with screening whereby the rejections have happened, and examples are these are no sample taken number on the form, training issues, inappropriate labeling, empty pots arriving, transport agents because the pots haven't been closed correctly, the wrong date for the recall on cervical screening, for example, 3 months outside of the 3 months has been sent in, they'll be rejected. Out-of-date vials are still happening actually, and samples stored in a fridge over the weekend, not a good idea. So it's worth thinking about how to reduce the chances of these happening. Next slide, please. I mean, I've covered most of these tips here, and it'll be on these slides when they come round. So next slide, please. And these are the final resources. One area, apart from Cancer Research UK and Macmillan, that I would really be a huge advocate for is Gateway C. These are learning modules, podcasts, and cancer maps. Absolutely superb for anyone dealing with cancer as a health professional. Absolutely essential. For those GPs and nurses who need PDP items, CPD items, this is a brilliant free resource which you can do, and the great learning, very simple modules to do. And I think, next slide, please. I think I've covered most of these things. So any questions from anyone, please? Any thoughts, any ideas, any comments? We will circulate these slides out to everyone. I've rushed through them just because I wanted to make sure I covered quite a lot of it here. But we will certainly send the slides out. Michael.
Sorry, I was trying to take myself off mute and put myself on camera. Just a question about targeted lung health checks. I'm in BSW. One of their practices of PCNs is actually at the moment refusing to participate in the lung health checks because they're concerned about the additional workload that is going to be created. And certainly talking to GWH, they reckon there is a sizable amount of findings which aren't cancer, that obviously primary care are going to be expected to manage. I just wondered if that's an issue that you've seen within Bob.
Michael, that's such a good question. You know what? It's a common question, I have to say, because like you, when I first heard about this and the incidental findings, the non-cancer findings, you're talking about maybe 60% of patients who have been through the screening weren't found to have cancer, but had other incidental findings like coronary artery calcification or some sort of lung disease, COPD, or etc. Right? So you're absolutely right, and there is definitely going to be some increase in workload. But what we've been working on with each of the systems is to write the incidental findings protocols. And what we've tried to do is to get those patients that shouldn't be coming to primary care. So, for example, it may be that they've got advanced coronary artery disease. Well, it may be that it's so bad that actually GP would probably end up referring anyway, right? So we've talked to the cardiologist and got their advice. So there's different grades. So very mild will probably not go to secondary care. Severe will definitely go to secondary care. Moderate, there's going to be a discussion about what needs to happen for that patient. So it may just be simple sort of preventative measures taken like a statin or whatever, right? So I think there will be some increase. Things like COPD, severe COPD might actually go straight to secondary care, but mild COPD will come back to primary care to manage. The advantage of that is that it becomes a chronic disease process, right? So it'll add to our register and we'll manage those patients. So what we've tried to do in a very roundabout way, what I'm trying to say is that we've actually got protocols now designed so that only those patients that need to be seen by a GP are sent to the GP, but the serious ones will all go to secondary care. Now, there is a lot of self-management required because some of the incidental findings actually don't mean a lot. Nothing needs to happen. They'll be sent a text message or a letter which explains what they ought to be doing to look after themselves. So although there is going to be some increase in workload, your registers will improve, the health of your patient will improve, and you will benefit, although of course there'll be a little bit of workload there, increase in workload. But majority of patients that are severe or even moderate in some cases will be going straight to secondary care.
I'm sorry, I was on mute again. And would you be? Could someone from TVCA send us on the protocols that you've developed? I'm fairly new in post, so.
Okay, yeah, of course we will do. We will do, of course. Yeah, of course we will do. Now the Swindon part or GSW part have actually progressed targeted lung health checks considerably. They're ahead of the game in the whole of the alliance. They've been doing it for a year and a half now. So actually they've got it down to a T in a sense. But yes, certainly we will. And the other areas of learning, the West Berkshire targeted lung health check hasn't started. It's due to start next year. Oxfordshire and Buckinghamshire have already started to a good degree already for the last few months. But yes, we'll send it on to you, Mike. If you put your email address in the chat box, please, Michael, we'll make sure that we circulate that as well. Peter, good to see you.
Hi, Anna. Good to see you, and thank you for your presentation. It was really helpful. I'm a GP in Oxfordshire, and I'm also clinical lead at Bob ICB for quality and medicines optimization. So I've got a question to ask, and it's really about practicalities here about the fit testing. So I'm interested to know how other colleagues follow up their negative fit tests. So the positive ones, well, that's simple. We know what to do with those. The reason I ask that is actually, we're working in a different environment now, aren't we, with different clinicians, not necessarily GPs, doing consultations, requesting investigations, and also we're not all there every day at the practice. So I'd be really interested if people could put in the chat whether they have any policy protocols around follow-up of negative fit tests, or whether this is an area we need to explore perhaps as a collective, because I think there was a bit of I'm not sure it's always happening, that 6-week kind of follow-up.
No, again, really good question, which I tried to address a little bit with one of my slides. But basically, there are a few elements to this, and others probably have a better idea than I've suggested. But really, it is about patient education. It's about making the patient understand why the fit test is being done and why, if that is positive, what we're going to do. If it's negative, what we're going to do. So it's getting that engagement with patient that's important, and making sure they make contact with the practice.
Yeah.
There is a reason why those symptoms are happening, right? So that's the first thing.
Yeah.
Secondly, what I'm doing and what I'm saying to some of my practice staff, whether it's paramedics or nurse practitioners or GPs, is task yourself so that you actually have it on your list to check up a week or two later whether a fit test has been done, one, and secondly, what was the result. So these are sort of safety netting techniques individuals are doing. And I would suggest really that these patients need to be followed up. So somewhere along the line, you can either even schedule on your diary that I need to check this. You can task yourself. You can send an Accurx message to the patient saying, have you done your fit test? Can you please check with us, organize a review for a consultation? You know, those are all tips that you can make. But it's very individual, I have to say, and practice-led, really.
Okay, and then I've got another question is, have you got a patient information leaflet that says that information around, you know, well, I mean, I always say to patients, if it's positive, you know, we go down the 2-week wait, but have you got something that says what you do if it's negative? Because that would be quite helpful.
No, we don't have a negative leaflet. So first of all, we have a positive leaflet, as in why the test is being done.
Yeah.
And there is a Cancer Research UK have done a really good leaflet, which you can actually download and use, which actually explains the benefits of doing it. A negative leaflet, unfortunately, is not an easy one to write because there may be so many reasons why it's negative. And I think we don't want to alarm patients, but we can look at it. We can look at a negative leaflet and come up with something.
Yeah, I think maybe even if it was something like, you know, if your fit test is negative, but you have ongoing symptoms, we might need to investigate you in a different way. Something like that. I mean, I'm just pulling out sentences, but maybe that's the conversation. Those are the words we need to use actually at the consultation. Okay. Thanks, Anna.
No, that's a good suggestion. So we'll come up with something like that.
Yeah, that'd be really great. So we could have both together. Yeah, lovely. Thank you.
Yeah, no problem. Any other quick questions before we go on to pancreatic? I think Ardens, I think you can actually have something in there. I think if you look at the template, there's something on the template which actually suggests that you can link it in somewhere. But we'll look at these sort of safety netting elements that we just mentioned. So thank you. Okay, interest of time, let's go on to Europac, because if you have any further questions, please put them in the chat box or let us know by email. Okay, so just want to introduce Ellery Hughes, who's going to talk to us a little bit about the Europac and pancreatic cancer. Over to you, Ellery.
Thank you. Do you mind if I share my screen?
Please do.
Okay. So Europac is the European Registry of Hereditary Pancreatic Diseases. So we're a registry that's been around recruiting since 1997, and says 2,300 families registered there, but it's actually 2,400 now. We also run a study testing the efficacy of the surveillance protocol to meet NG85 guidelines. So because of this, we offer surveillance for high-risk individuals. So the surveillance is a combination of a cycle of CT, EUS, MRI, and blood tests, which is CA19-9 and HbA1c, which is annually. And the surveillance programme is a joint piece of work with NHS England, and all about establishing the referral route through the NHS. So I am new, well, not new, I say new, 18 months in my post as a navigator, but the role is relatively new compared to the length of the trial. It's currently an open-ended study and was supported by University of Liverpool, PC UK, NHSE, NIHR, and Cheshire Merseyside Cancer Alliance. So our eligibility criteria for the FPC, the familial pancreatic cancer cohort, is 2 or more first-degree relatives of kinship, so that have been affected by pancreatic cancer, or 3 or more relatives affected by pancreatic cancer, regardless of relativity. or carriers of no genetic mutation with one family member affected by pancreatic cancer. So certain mutations that we accept or we see often is BRCA1 and 2, ATM, PALB2, Lynch. That's all I can think of at the top of my head. Or just carrier of Peyer's without any family history. For our hereditary pancreatitis cohort, it's 2 or more relatives with idiopathic pancreatitis, or families with at least 1 case of pancreatitis and the confirmed mutation of PRSS1. Just because if a patient is eligible for the registry criteria, they fit this criteria. It doesn't actually deem them eligible for our screening. They have to go through a risk assessment. They are discussed with our clinical team in an MDT, and they look at all their history and the family history and their medical history. So these are the main referral routes. We've got secondary care, genetics, and then primary care. So obviously GPs are referring an individual with family history, with a known family history of pancreatic cancer. We do actually have a SNOMED, well, there is a SNOMED code that is already available. I can send out these slides afterwards if you'd like to have a look at the code and stuff like that. So this is our current referral form. So healthcare professionals can fill out this form and then send it over to myself, where I can then start the registration and send out the registration documents to the patient. Or the patients can just go on the website and contact us directly. So you could signpost the patient to the website. Or you can just email me with patient details where I can follow up with that. My email's there. Again, I'll pop it in the chat afterwards. So this is our pathway for patients. So staff refer the patients to the coordinator or the navigator to me. We then contact the patient or the participant, and then the risk is calculated at an MDT. Sometimes the individuals are referred to genetic testing, but patients don't need to have an identified mutation to be eligible for surveillance. Then if they are found eligible for surveillance, this is then coordinated by the navigators at regional centres. So I believe we are in setup for one in Oxford, and we have one in Bristol, and then there's set up one in Cambridge, which is my areas. So my areas are Thames Valley, Swag, and East of England, so just that little strip. And then we then advise on actionable findings, coordinate an MDT as needed, and then obviously the NHS Trust will treat the patient. And then we then produce progress reports, including numbers that are enrolled and actionable findings. So the current referral numbers within Thames Valley, so about 76% of the referral numbers are actually self-referrals. This is kind of across the board. We find self-referrals as our main mode of referral. Secondary care 9% and genetics 15%, but we currently have 0 referrals from primary care in the past year. So, and then we've got our referrals from the past 6 months. They are slightly going up, and then August dips down. I feel like August is just not the best month for anything, really, not a productive month. So how do we target primary care? So we've got a referral form that could be embedded into EMIS or System 1, depending on what you use. Leaflets, posters that can be distributed to GP practices. There's an example just on the side there of one of our posters. We've got awareness raising via text messaging. So I think it was West Mids, they have done a Cancer Alliance wide text message where just to ask patients whether they've got this certain family history and to contact Europac basically. And then we also offer a virtual drop-in session by Cheshire and Merseyside Cancer Alliance, which is once a month, which is kind of like a Q&A for anyone who just querying anything about the trial. So what do we ask? We ask that you simply ask questions about family history of pancreatic cancer or pancreatitis, and then share my details and refer. There's the general contact information for the Europac office, and then there's also my contact details, which I can just pop in the chat for you if need be. Any questions?
Very clear, Larry. Really, really good. And I don't know about you guys, but I've certainly seen an increase in the number of diagnoses of pancreatic cancer in my practice. I don't know if others have seen that as well, but this is quite clearly it's a very, very serious illness with really poor outcomes. And I think if we can be very proactive, so it's a really good one. Thank you, Larry. Really great.
Thank you.
We would like to share the slides as well with everyone, please. So do we have permission to do that?
Yeah,
that's
of course.
great. Thank you.
You want me
Thank
to
you.
email the slides over to you? Yeah.
Please do that. Please do that. I think certainly primary care as a role, given the workload we have, it may not be easy, but simple searches with the SNOMED code, as you said, maybe sending out the text message or the leaflet that you were promoting might actually help. So certainly brilliant. Thank you. Any questions for Larry or any general comments on the process that's been mentioned? You've blown them away, Larry. You've blown them away all. I think this is fairly new, so I think people may need to sort of think about it. And it could be part of your PCN DES, actually. It could be another cancer you're sort of looking at, and really good audit to carry out as well. Finding one pancreatic cancer is going to change people's lives, okay? So I think it's a really good one to look at if you have the interest or the reflection on it from the patient's perspective point of view. Thank you.
Thank you. Thanks for having me.
Yeah, thanks, Larry. Okay, any final thoughts or comments from anyone in terms of cancer and the PCNs, practices, anything particular? Very quiet today, all of you. Larry, they're normally very vocal, you know that. Lots of questions usually. Anything else from anyone? Anything that the Alliance can help with in PCN land or practice even? Is there anything you'd like to hear about? Any more support we can give you? Any questions we can answer for you or come and get in touch with you? Anything that we can help from a PCN point of view? Katie, anything from you at all from a Bob ICB point of view?
I was just going to add to the question about the lung cancer screening program that there is the National Incidental Findings Protocol has been approved now only very recently, I think at the beginning of last week. So Michael might be interested in looking at that as a adjunct to all the different local interpretations of that.
Yeah, no, good point. The problem with the national protocol, it is very much an overview and it's local interpretation, you see. So what we've done is we've taken the national one, reviewed the local ones, and actually they're in concordance completely. But yeah, absolutely right, Katie. Yeah, good point. But local ones are slightly different because of the services. Michael, did you want to come back on that?
Well, only the question wasn't, and thanks, Katie, where is that?
It's on NHS Futures targeted lung health check website, but I can send that over to you. That's no problem at all.
If you would, and I will look on Futures. We're still trying to map the different data sources available to us. My entire team and you pretty much following the ICB restructuring. So we're playing big catch up, I'm afraid. So
Michael, I'm the clinical lead for the targeted lung health checks for the Alliance, and we have Kirsty, who's from Swindon, actually, who's supporting the Alliance as well as your area, and we'll send both of these to you, the national ones as well as the local ones. All right, so we'll try and get those to you. So yeah, thanks, Katie, as well. So if you want to forward that on as well, please do as well. That'd be really useful. Excellent, good. Anything else from anyone at all? So, Michael, this is your first meeting, I assume. So how does it feel? How was that information for you?
Actually, interesting. I'm not a clinician. I've been around a little bit. I have spent some time. I actually worked at the Royal Marsden for 4 years as an ops manager, so I'm not entirely without some knowledge of cancer. But my my role includes plan care as well. So whereas previously we had two senior managers responsible just for cancer, that's quite different now. I mean, as you'll understand the nature of the restructuring that ICBs went through and the amount of headcount that we lost. So yeah, we're just we're trying to play catch up, and obviously my challenge to a degree is that the majority of our population is covered by SWAG. And I'm quite keen to make sure that we don't have differential arrangements between the Swindon area, TVCA, and SWAG. So it's early days. It's early days for me and my team. So yeah, but yeah, I mean, really interesting, and I'm looking forward to seeing the slides because I think it's an eye opener for me about a lot of this stuff. So yeah, that it was a good presentation and a lot of information in there. Thank you.
No, that good to have you, Michael, as is good to have everyone else, and certainly we'll share the slides and everything. And Michael, if you have any insights, we'd very much like to work with you. If you have any new ideas from the Royal Marsden, that'll be even more welcome.
That was a long time ago, and that was a long time ago when I was up to dealing with some of the more challenging medical staff. I think it's fair to say.
Okay, all right, but we're always open to new ideas and new ways of working. So just let us know and keep coming to all the meetings that we have, which would be great. Okay, well, I'll give you 10 minutes back to all of you. Thank you all very much for coming today. Any questions or queries, get back to us, and keep well and happy.